Hello everyone. I'm Nirja Shah at the Illinois Chapter American Academy of Pediatrics, and I thank you for joining us for today's webinar on the ROG Faculty Training. This is sponsored by the Illinois and Chicago Departments of Public Health. Following this webinar, you will receive an email with a flyer with all of our vaccine summits and webinars for the year. You'll also receive the slides from today's presentation, the recorded webinar, W-9 form, and speaker honoraria. Please sign and return the W-9 and speaker honoraria forms to me by the end of this week. Participant phone lines are muted. This webinar is being recorded. If you have any questions for a speaker during the presentation, please enter them into the question box on the control panel for the webinar, and it will be answered at the end of the presentation. Today we're joined by Dr. Anita Chandrapuri from Northwestern Medical Group. First, I'd like to introduce her. Dr. Anita Chandrapuri received her medical degree from Northwestern University School of Medicine and conducted her residency at Children's Memorial Hospital in Chicago. She currently practices pediatric medicine at the Northwestern Medical Group in Chicago and serves as an instructor in clinical pediatrics at Northwestern University School of Medicine. She is board certified in pediatrics and is a fellow of the American Academy of Pediatrics. Please join me in welcoming her.
Hi, everybody. I think I know everybody here except for Jenna. We have a very small audience, and most of you have actually done the Reaching Our Goals presentations before, so this is going to be very informal. And honestly, I'd love some feedback on the slides. If there's anything that you think we should change up, because these are going to be slides that you present with, please make sure you let us know. This is a slightly different slide deck from the years past. Nirja has done a fantastic job of really whittling out sort of the repetitive slides, and they have a different face to a lot of them, so slightly different in terms of what they'll look like, a lot of the same content, but definitely let us know at the end if there are slides that you think should be changed or there's ways to improve this. And I'm really going to run through most of this briefly. Like I said, most of you have already done this before, and so it's not a lot of new material. So I think the slide, there's a total of 54 slides compared to 70, 80 slides in the past. One second. Of course, we're having a little bit of technical difficulties with just getting our slides to flow forward here. There we go. What'd you do?
I have no idea. Just move the mouse.
Okay. All right. Oops. Okay. So the first slide, of course, is the presentation slide. The next one is going to be disclosures, which you're just going to want to mention if you have any specific disclosures. Sorry, we're still having technical difficulties with this. There we go. That the funding and support of this presentation is from the Illinois and Chicago Departments of Public Health. You will be focusing on slightly different things with each group of offices you go to, but the presentation slide deck will be the same for all of them. So the outline, again, is updates on immunization schedule, vaccines focusing on the 0 to 3 year age group, the influenza vaccines, specific school entry vaccines, then we talk about the adolescent vaccines, the HPV vaccine specifically. There will be some general immunization, frequently asked questions, and then what the physicians or nurse practitioners can do to improve vaccination rates and reduce missed opportunities in their own practices. We included the 2015 schedule, which it's always good to point out what it looks like just so people can refresh their memories on what this is and make sure that they update their schedules in their offices, whether it's posters on the wall or whatnot. And then I like to just always point out the range of recommended ages, the catch-up immunization ages, high-risk groups, and things we need to do with specific high-risk groups. It's nice when they have the schedule in front of them to highlight some basic things like the recommendations for the influenza vaccine, the issues with the MMR vaccine, specifically for those who are traveling abroad. I like to point out the footnotes for each vaccine, and then any specific other languages or any specific other language details that are in the ACIP schedule. This year, There is more specific recommendations for the use of the different styles of the meningitis vaccine. The influenza vaccine footnote was updated, and the pneumococcal vaccine footnote was updated to provide clearer guidance for people with high-risk conditions. Again, a lot of this you want to just talk to the providers in the practices you're going to so that they can see the information on their ACIP schedule. It's very hard for anybody to memorize this, and so I just always make sure I point out the new schedule every year. The ACIP recommendations for 2015 specifically, the meningitis B vaccine, patients are to complete a 2 or 3 dose series depending upon the vaccine without a preference. There is a new 9-valent HPV vaccine which has just been recommended for ages 10 and up. Currently, age and gender recommendations are the same as for the quadrivalent HPV vaccine. Right now, the recommendation is just to finish the series with whatever vaccine is available. There's no change yet in the 3-dose schedule. It should be given at time 0, time 2 months, and then 6 months later. And there still isn't a specific recommendation on what to do with those who have already been vaccinated with the bivalent or quadrivalent vaccines in terms of any booster dosing with the 9-valent vaccine. As I've been told, ACIP is going to be discussing this further at the June meetings. And then with the flu shot for all children 6 months and older, it's still recommended to be given annually, and there's no preference for children to receive the live attenuated mist over the injectable inactive vaccine or the shot. There's some specifics about the catch-up schedule. Specifically for Hep A, B, polio, meningococcal, MMR, and varicella vaccines, where it's whited out and it's not really in the recommended age group. That's not really supposed to be applicable for those specific vaccines. So this slide is pretty similar. Everybody's probably seen this one with the measles, pneumococcal, pertussis, and Hib periorbital cellulitis pictures. We added in a different video, which I'm not sure if I can actually go to show you what it's like. Let's see if it goes to that. Oh, it does. Are you all? Hopefully, you're all seeing this. But it is a specific YouTube video that we put in. No. Hopefully, you're seeing this.
That began at Disneyland in December has now spread to more than 90 people in the U.S. That has the CDC urging people to get vaccinated against the highly contagious disease.
It's one of the most contagious viral illnesses that we know about. In fact, you can, the virus could be in a room, actually in the room for several hours after a person leaves.
And it can be deadly in young children, especially babies who can't get the measles vaccine until they're 12 months old. So some doctors are taking a stance against parents who choose not to vaccinate their children.
So this is measles, mumps, rubella.
This California pediatrician is no longer accepting patients who have not been vaccinated.
All those other kids who could get measles, we need to protect them. And I can't do what's right for the 10 or 20 people and let the other over 2,000 go by the wayside.
The CDC says it doesn't hurt for adults to get an extra dose of the vaccine.
Okay, so that's sort of, oops, I just click on it. This will be something to break up the,
Storm drained southern Taiwan, forcing thousands of evacuations.
That's not what you wanted. Okay. There we go. All right, so make sure you play around with that in your own, on your own laptop or before you present. But we thought that that would break up just having pictures to actually have a video. This slide is the same slide that's been in every ROG slide deck for a while now. It's always good to point out the decrease in number of cases of each of these diseases and to highlight still the concerns we have about pertussis and to talk about the individual diseases. You know, we can always branch off of the measles outbreak this year with the individual providers. So let's actually talk about the MMR vaccine recommendations. Routine dosing is the first dose of MMR vaccine is given at 12 to 15 months. The current CDC recommendation is to actually err on the side of the earlier date, so go with 12 months. Second dose can be given 4 weeks later, but it's usually given before the start of kindergarten. It's recommended at 4 years of age. If any of your patients or any of your providers' patients got the vaccine, let's say at 2 or at 3 because of concern that the parents or the providers had, that is okay as long as it's 2 doses given appropriately spaced apart after 12 months of age. And the schools will be receiving information about that so that the school nurses will also be able to accept those 2 measles vaccines. For international travelers, infants 6 months to 11 months of age, 1 dose of the MMR vaccine may be given, but it does not count as their official MMR vaccine, so they will still need to get 2 doses separated by at least 28 days after 1 year of age. The same with adolescents. We want to make sure that the adolescents also have documentation of 2 doses of the MMR vaccine at least 28 days apart. Chickenpox, varicella, it's most often a benign illness, but it can be deadly. We want to make sure that we talk to our providers about the routine 2 dosing of the vaccine, first given at 12 to 15 months, a second dose typically given at 4 to 6 years of age. There should be a spacing of 3 months between first and second doses if they are under 13 years of age. Over 13 years of age, the spacing can be 1 month apart. It can be acceptable to schools if it's at least 1 month apart, but the recommendation is usually 3 months apart for under 13 years of age. Hepatitis A and B. Hep A, liver disease caused by the virus. It usually causes stomach flu-like symptoms, mainly in adults. It's spread from children to adults, and adults can develop more severe infections. Routine vaccinations recommended at 1 year of age, with the booster 6 months later. Sorry, I need to go back up again. There we go. Oops. I can't get rid of that bar there. There we go. Hepatitis B is a contagious silent infection that we know is spread through bodily fluids. Many of those who get it have no known exposure. Complications from Hep B are far more likely to develop in infants and young children than they are in adults. So we definitely recommend vaccination at birth. Second dose 1 to 2 months later. Third dose is at 6 to 18 months later, or is at 6 to 18 months of age. The reaction at the site can just be soreness, fever, irritability for a day or 2, but it's very rare to have any kind of an allergic reaction. I have never personally seen fever as a reaction to the hepatitis B vaccine, which is why I think that it's completely safe to be given at the birth dose. Parents often worry and wonder about that, but I really feel very comfortable giving it at the birth dose, and it's really important for us to encourage providers that we're talking to about giving the routine birth dose vaccine as well. DTaP recommendations. Of course, it's important to talk about the 3 parts of this vaccine, the diphtheria, tetanus, and pertussis, even though for the most part we seem to be vaccinating for the pertussis reason. Almost nobody gets diphtheria or tetanus in the United States, but around 1 million get pertussis every year, and it is especially serious in infants. So the vaccine is given at 2, 4, 6, 15 months of age, and then at boosters at age 4 and at 11. All adults should also be vaccinated now, and women should be vaccinated with the pertussis-containing vaccine at least with every pregnancy. The vaccine is incredibly effective. Side effects are much lower with the current vaccine compared to the cellular pertussis vaccine that we used to use before. And some people certainly may ask why pertussis is still so common, and it's up to your comfort level to talk about the different reasons why. The fact that there's waning immunity after a certain period of time, that there are pockets of people who have chosen to be not immunized, that there is some concern that the acellular version of the pertussis vaccine is not as effective, but if we make sure that we vaccinate everybody, it reduces the community burden of pertussis. So it's certainly important for you to feel comfortable talking about all of that with the providers you're educating. Polio vaccine, certainly we still need to vaccinate against it, or vaccinate against polio to make sure that we fully eradicate this disease. There are only 3 countries currently that have polio endemic to them, but it could resurge if we don't vaccinate just because of basic herd immunity. The routine vaccine is given at 2 months, second dose at 4 months, third dose at 6 to 18 months, and then the 4th dose is given for school entry. PCV13, Streptococcus pneumonia is the most common cause of bacterial meningitis. It also causes pneumonia, blood infections, and ear infections. Everybody benefits from this vaccine, but we think of using it most effectively against preventing severe complications from strep pneumo, but it also does reduce the incidence of ear infections and the need for ear tubes. The routine vaccination is given at 2 months, 4 months, 6 months, and 12 to 18 months. And then in terms of catch-up, 1 dose at 24 to 59 months for children who were not completely vaccinated. Pretty much every practice should only be receiving the PCV13. I don't think that there's any practices that will still have any PCV7 stock around. If they do, it's got to be outdated. Rotavirus, a common cause of viral gastro from years past. Fortunately, with the use of the rotavirus vaccine, we have seen a definite decrease in rotaviral infections in children. The initial concerns with the use of rotavirus vaccine are a great demonstration for how regulatory agencies react when there is a concern about the vaccine. Some of you may remember the rotavirus vaccine that came out in late 1990s, which caused some cases of intussusception, and with quick reports to the VA-ERS system and investigation on the CDC's part, that vaccine was pulled off the market. A totally different rotavirus vaccine has been used since then and has been a safe choice of vaccine and has really, really decreased the burden of rotaviral infection in our population. Hib vaccine, this is either a 2 or 3 dose primary series depending upon the specific vaccine that is used. After the primary series, a booster dose is given at 12 to 15 months of age, and this is something that you're going to need to talk to the specific practice about in terms of which vaccine they use in their practice. Influenza vaccine, Jen Burns is our expert on this, but pretty much who gets influenza? I like these slides that Nirja put in now. Who gets influenza? Almost everyone will eventually. So who should get vaccinated? Everybody should. There are 2 types of vaccines. There's the live, nasal, and the injected shot vaccine. Each works against either 3 or 4 strains, depending upon if they're trivalent or quadrivalent. The live nasal is all quadrivalent. The vaccine is known to be effective. It depends upon the season, but it is always more effective than not getting it, and that is the most important point to let people know. The biggest side effect everybody always wonders about is, can you get the flu? And no, you cannot get the flu from the flu shot. And again, I'm speaking to you guys all know this, but these are things you want to really drive into the minds of the people you're teaching. There are yearly epidemics and sporadic pandemics of influenza. Basically, virus mutations create new strains, and so that is why you need to be vaccinated every year. And if you think about it, this is a wide range, but 5 to 20% of the United States population is infected annually with influenza, so it's a significant issue in our country. Who is infected? Illnesses can occur in all age groups. The highest risk populations, of course, are young children and elderly patients, pregnant women, people with asthma, diabetes, heart disease, neurologic conditions, chronic renal and liver disease, or compromised immune systems. Vaccination annually is the best way to prevent illness after 6 months of age. And then for younger than 6 months of age, we hope that their family members cocoon them and protect them from getting the illness. So the universal recommendations are vaccinate everyone 6 months of age or older unless contraindicated, and there are very, very few contraindications against flu vaccine. I love this slide she put in now. Are vaccines safe? If safe equals harmless, then no vaccine is 100% safe, but very few things are harmless. If safe equals preserving from real danger, then vaccines are very safe. There's a nice explanation that you'll be able to see when you get the slide deck, which I think is just nice, simple stats. In the United States, 350 people every year die in bathtub accidents. 200 people every year die from choking to death on food. 100 people die every year from lightning strikes. But remember, even though 15 out of 1 million children developed intussusception after the first rotavirus vaccine and 1 child died, if you took 1 million unimmunized children, 16,000 would be hospitalized with rota and 5 to 10 would die from it. So I think it's just really, really important to put this in perspective, that for all vaccines, the benefits far outweigh the risks. There is a system in place when any patient or clinician has concerns about vaccines, but really, really, truly, vaccines are one of the best things that we can do to help protect our patient population. Are infants too young for immunizations? Infants are immunized because infancy is when they're the most vulnerable to many diseases. Particularly when we think about pertussis, more fatality or more mortality is seen more morbidity is seen in children under 6 months of age. Children under 2 years of age are 500 times more likely to get Hib meningitis if someone with a Hib infection is living in their home. And 90% of newborns of mothers infected with Hep B will develop chronic liver disease. Patients often worry that their infants have immature immune systems and can't really respond to the immunizations. That is incorrect. They have fully responsive immune systems. It's really important for them to understand that that's the best time to protect their children. I think a big push from the AAP is to not think of delayed vaccination schedules as alternative schedules. Alternative implies that you accept that it's an alternative. The AAP does not accept any alternative schedules. They are delayed schedules, and they are not what are recommended at all. So the AAP fully supports the ACIP's recommendations on vaccines, as does the Academy of Family Physicians, as does the American College of Obstetricians and Gynecologists as well. So with their support, we really encourage the ACIP schedule. Okay, on to vaccine requirements for the school year 2015-2016. For public and private schools in Illinois, the requirements include DTaP, polio, MMR, chickenpox, Hib, and Hep B. The pneumococcal, rotaviral, flu, and Hep A vaccines are not requirements for school. In Illinois, there are two different kinds of exemptions that are allowed, either medical or religious. There are no philosophical exemptions. Medical exemptions would require physician or clinician documentation of the reason for the medical objection. Religious objections are validated by the local school board, and there is currently a lot of work in progress trying to clean up the religious objection forms that are used, but it is something that is validated by the local school board. In terms of changes for this upcoming school year, the meningococcal vaccine requirements, 6th graders must show 1 dose of meningococcal vaccine at school entry, and then 12th graders must show 2 doses of meningococcal vaccine at school entry. The second dose must be administered on or after the 16th birthday. And there are, of course, exceptions to this. If the first dose of the meningococcal vaccine was administered after the 16th birthday, then only 1 dose is required. And the new child health exam form will have revisions in it which will accommodate the meningococcal requirement in the form. And this is an example of the rollout that is being done for the varicella requirement. This past year, 2014-2015, proof of 2 varicella vaccine administrations were required at kindergarten, 6th, and 9th grade entry, and then this next year it'll be for kindergarten and 1st grade, 6th, 7th, and 9th, and 10th grade, and you'll see that it just rolls out because they require it at the same time, and so with each subsequent year you'll see that every child will be accommodated within that 2 varicella requirement. In terms of school compliance, these are some basics that the school board follows. In terms of mandated intervals between shots, 1 month is considered to be 4 weeks or 28 days. 2 months is considered to be 8 weeks or 56 days. 4 months is 16 weeks or 112 days. 1 year of age means on or after the first birthday. For preschool hepatitis B only, 6 months of age is a requirement for that Hep B vaccine, and that's 24 weeks separating the first and the third dose of the hepatitis B vaccine. When the interval is less than 28 days for a live virus vaccine, the vaccine administered second should not be counted as valid and must be repeated. A 4-day grace period can only be allowed with the provider note. It counts as a medical exemption. It's not acceptable, though, on the 2 live virus vaccines. And in terms of laboratory evidence of immunity, it's either IgG titers, I can't see this very well here, but hepatitis B infection, you would show titers against Hep B surface antigen. Lab evidence of immunity is not allowed for Hib, pneumococcal, diphtheria, tetanus, pertussis, and polio vaccines. You must actually show vaccination records for those vaccines. This really affects public and private schools. Because there are different age groups for different there are different ages when children enter different grades. the standardized age for kindergarten is 5 years of age. For 6th graders, it's 11 years of age. For 9th graders, it's 15 years of age. So you have to actually comply. So if you're in an ungraded school system, you have to comply with the grade equivalent. Hopefully that makes sense. Medical objections must indicate what the medical condition is that contraindicates a specific immunization, and it must be written by a healthcare provider, either an MD, a DO, an APN, or a physician's assistant. As I mentioned, the religious objections are being worked on currently at the governmental level. This currently is a personal religious belief that the local school authority either accepts or denies. Currently, the way it stands, an individual has to detail a specific religious belief which conflicts with the specific immunization and or exam, and it has to be in writing, and it has to be presented to the school authority, who then decides whether or not they will accept that. What about adolescents? Reasons adolescent immunization is crucial: it prevents long-term sequelae of serious illness like cervical cancer, which is caused by HPV, cirrhosis of the liver, which is caused by hepatitis B, or of course complications from meningitis. Adolescent immunization is crucial to increasing herd immunity when it comes to things like pertussis and influenza and varicella. In the adolescent time period, we can still take advantage of parental insurance coverage or VFC programs. We all know that adolescence is a time of new environments and new risks with travel and summer programs and various experimentation, and so we need to make sure that we capitalize on physician trust and bond that's developed over the years to encourage our adolescent patients to receive the immunizations they need to actually have. Vaccines recommended for our teens: the Tdap booster, 2 doses of the meningitis vaccine, 3 doses of an HPV vaccine, and the annual influenza vaccine. So with Tdap, there's the Boostrix product, which is licensed for 10 years of age and older, and then there's Adicel, which is licensed for 11 to 64-year-olds. The current recommendation is for 11 to 12-year-olds to receive their first Tdap booster, or currently their only Tdap booster. Catch-up is between 13 and 18 years of age, and children who are 7 to 10 years of age who are not fully vaccinated with DTaP can also receive a Tdap vaccine. The meningococcal vaccine, like I mentioned earlier, is preferably given at 11 to 12 years of age with a booster dose at 16. The HPV vaccine, HPV infection rather, almost all females and males will be infected with HPV at some point in their lives. There are 14 million new infections per year in the United States, and it's the most common infection in people in their teens and early 20s. Most people will never know that they have been infected. I kind of liken this to the common cold of sexual activity. HPV exposure can occur with any type of intimate sexual contact, so intercourse is not necessary to become infected, and that's the most important point to drive home to our providers, who then need to go on to talk to their patients. Nearly 50% of high school students have already engaged in sexual vaginal penile intercourse. 9th graders, a third report have been sexually active. By 12th grade, 2/3 report sexual activity. A fourth report that they've had 4 or more partners. And if we look at the average number of new HPV-associated cancers by sex in the United States, about 30,000 plus new cases of cancer associated with HPV. In women, it's cervical cancer. In men, it's oropharyngeal cancer. HPV is a preventable illness if we use the HPV vaccine effectively. Since 2006, over 60 million doses of the vaccine have been distributed. The most common adverse events associated with the vaccine were mild. Soreness at the site. Definitely we see patients who feel lightheaded, but for serious adverse events, there have been no unusual patterns that would suggest the events were caused by the HPV vaccine specifically. Findings of any adverse events are similar to the safety profile of the meningococcal and the Tdap vaccines. We still don't have the best coverage levels, though, for the HPV vaccine. And if you say, well, is it because we're just not vaccinating adolescents as well? That doesn't seem to be the case when we look at the Tdap and the meningitis vaccines. So we really need to do a strong push to get HPV vaccine accepted by not only our patients, but the providers who are administering the vaccines as well. in both girls and boys, make sure that the providers understand that it is recommended equally for both girls and boys to be given 3 doses of the HPV vaccine starting at 11 years of age. Strategies to approach the HPV vaccine. You can talk to providers about having a reminder recall system in their offices, either at a provider level by having electronic medical record prompts, or at a parent-patient level by having postcards or telephone calls or text messaging, or even the little magnets that light up when the next dose is due. You can have standing orders in your electronic medical record system. You can make sure that providers are assessing all the vaccine doses that have been given to their adolescent patients at every adolescent visit. There are different programs that are out there to help assess vaccine coverage levels, to help instruct providers about what they can be doing differently at their own practices. And then as a provider, you can make sure that you're telling the people you're teaching to make sure that they give strong recommendations about the vaccine, about starting the conversation early and focusing on cancer prevention as opposed to the sexuality of this vaccine or this illness. Offering a personal story sometimes helps. And even just sort of role-playing with the providers you're talking to about the questions that they may be asked from parents. This is the part of the Reaching Our Goals presentation that Nirja has really weaned down for us. In terms of contraindications, there's only 4 true contraindications to vaccination, either an anaphylactic reaction to the vaccine or vaccine component, encephalopathy less than 7 days after a previous dose of a pertussis-containing vaccine. A severely immunocompromised patient would not be able to receive the live virus vaccines, and pregnancy would be a contraindication to receiving live virus vaccines. If a true contraindication exists, the vaccine should not be administered. There are contraindications other than those listed above that apply only to the live attenuated influenza vaccine. In terms of false contraindications, mild acute illness, low-grade fever, antibiotic use, premature birth except for Hep B, a stable neurologic condition, mild to moderate local reactions, or an immunocompromised family member or close contact are all false contraindications to vaccinating your patients. In terms of the reactions, there are local reactions to talk about, systemic reactions, and truly allergic reactions. And the best thing that the providers can do is to screen their patients or their parent or the patient's parents with each vaccination administration. So if we look at sort of categorizing these, birth to 3 years of age, Hep B, Hep A, rotavirus, DTaP, pneumococcal vaccine, polio, MMR, or MMRV or varicella, and influenza. I think we need to add Hib on there too. Yeah. And then school entry, DTaP, MMR, chickenpox, hepatitis B, pneumococcal, and flu, adolescent MMR, meningitis, Tdap, HPV, and flu. So on this slide, we'll add in the Hib. Thank you for listening. All right, we're going to open this up to questions and comments. Like I said, this was pretty informal, but certainly if you guys have anything that you want to change up or modify to make this a more comfortable presentation for yourself. Do we have Jen is asking, do we have an ICD-9 code we should be using to represent delayed vaccine schedules? You know, there is an ICD-9 code on parental refusal for vaccination and a delayed immunization schedule. And what I will do is I will get those numbers and I will send them to Nirja, who will email them out to all the participants of this webinar. What is the status of MMRV? In terms of, Leslie's asking, in terms of recommendation of its use or in terms of actual availability of vaccine? Availability. That I don't have an answer to.
I don't either, but I can get back.
We will get back to you on that one. Jen, can you speak to, if we put you live, can you speak to the egg contraindication issue with the influenza? As far as I understand it, the current recommendation is only if somebody has an anaphylactic response to egg, are they not to receive the influenza vaccine at a pediatrician's office. But other types of reactions to egg ingestion are not contraindications anymore. Is that correct, Jen?
Can you hear me?
Yep. Yes.
Yeah, that is correct. So pretty much what I do with my patients is that I ask them do they totally exclude egg from their diet? And that's really, really hard to do. And if parents say, I totally exclude it, then I go down and say, do you eat cookies? Do you do this? And if they totally exclude it, then I would say, okay, we need to give this flu vaccine with an allergist. But if they don't, I then administer the vaccine and observe them for 30 minutes.
Perfect.
So it's really anaphylaxis
Yeah.
and total exclusion of all egg products from the diet. And I think that's very hard for people to do.
Yeah, sounds perfect. Thank you, Jen. Thank you.
So,
Any other questions?
Here we go. This is a big question. Okay, hold on. The initial FDA approval of HPV-9 included females 9 to 20. Okay, here I'm just reading the question out loud. Males and HPV-9. The initial FDA approval of HPV-9 included females 9 to 26 and male 9 to 15 because the trial data was not yet complete for older males. Because of this, Humana in Illinois is currently covering only per label, not per ACIP recommendations, which means that Humana only covers males through age 15 for now. Merck has petitioned for an FDA label change for HPV-9 for boys through age 26, but this will likely take a year. Humana will continue to cover Humana will continue to cover HPV-4 for males through 26, so we could consider keeping some of our HPV-4 vaccine stock for Humana adolescents 16 to 26, though I do not want to make vaccination more complicated than it needs to be. I will let you know if this changes, but in the meantime, more reason for us to target younger adolescents. Blue Cross Blue Shield Illinois is covering per ACIP recommendations, so they will cover males and females through 26. I will also keep tabs on that. I know the Merck, many of you know Annie. Annie now works for Merck, Annie Boson, who now works for Merck, and she's keeping me in the loop on HPV-9 as well. Rachel, you have a comment, but not a question.
No, she's saying that was a comment.
Oh, okay. Got it. So I just read Rachel's comment out loud. Thank you, Rachel, for that. It's good to know. We certainly don't want to have providers feeling like they're stuck with big bills. Jen says, liked the slide that discussed need vaccine instead of serologies. Can we add or refer them to the catch-up schedule to help people to get these kids up to date? This is most relevant with adoption or refugees without immunization records. Do you mean adding? Can we add or refer them to the catch-up schedule? I think probably it's best to refer them to the catch-up schedule. Because on our slideshow itself, it's very hard for them to actually see it because we sort of fly through it so fast. Usually in the past, as you all remember, we hand them a packet of information that they keep at their practices too. And so we'll make sure that it has both the current ACIP schedule and the catch-up schedule. And then, of course, this year we need to make sure we point out to everybody that there is a new red book that's coming out that they should be able to access. Because it's 2015. Is that okay, Jen? Yes. Okay, Jen says yes. Don't you like how much smaller this slideshow is? Does anybody else have any? Yes, and cleaner. Good job, Nirja. Good. Does anybody else have any other questions or comments?
We can give everyone a few minutes.
Nope from Jen. Okay.
We'll give you guys a few minutes just in case any last-minute burning questions.
Thanks, Leslie. When will you start to schedule? Thanks, Rachel. Rachel said great job. Jen wants to know when we will start to schedule.
Schedule
office-based
We
trainings.
usually don't have office-based trainings this year.
Oh, we're only doing webinar.
Well, that's also on the edge. We're not. It depends on the deliverables for this year.
So it's still up in the air about where this will be presented.
Yeah, but most likely it's not going to be office-based. We have, I believe, a different kind of office-based training, but we're still getting information.
Okay, so then at this point, we'll wait to hear from Nirja and John and Anne
And Sandra.
about scheduling these talks. But you all at least will be our experts on it, and we'll go from there. Okay, well, thanks, everybody. We will talk soon.
Thank you for joining, you guys. After this, I'm going to send you guys an email regarding with all the attachments, like the slides, the recorded webinar, the W-9 forms, and the speaker honoraria. So just do your best to get back to me the W-9 forms and the speaker honoraria by the end of this week, if possible. Thank you.